Jim Fausto, who is Associate Director of the Palliative Care Service here at the University of Washington. It's been a terrific asset resource for us on the heart failure service here. He did fill me in on what FAAHPM stands for. It's
American Academy of Hospice and Palliative Medicine.
So he's well credentialed to give today's talk, which is entitled Intersections of Palliative Care and Advanced Heart Failure. So Jim has no disclosures. The sessions are supported by federal grants.
Thank you, and I'm really excited to be here and appreciate the privilege of being able to talk with you all. At the end of this talk, my hope is that you'll be able to have an ability to define palliative care. I hope you can sort of be able to summarize the current needs for palliative care within advanced end-stage heart failure. And then sort of, I wanted to touch on one clinical skill or area of knowledge, and so be able to review the palliative treatment options for dyspnea and end-stage heart failure. You know, one of the challenges of palliative care is we have a huge definition and has a lot of words in it. So to that end, it can mean a lot of things to a lot of people. But as best we can, one of the more standard definitions is put out by an organization called the Center to Advance Palliative Care, short for CAPC is short for that. And basically what we are is we're a model of care that works with patients who have serious illness. We tend to help with symptoms and pain and stress related to serious illness, whatever the diagnosis, so we can cut into many different areas of medicine. We tend to see the model of care as both the patient and the family, so not just the patient necessarily, which is where a lot of medicine focuses. And I think a real quick line when families ask you, what is palliative care? You can sort of, often they're satisfied with sort of, if you share, you know, it's an extra layer of support for patients with serious illness. So I think that extra layer of support is a piece that goes well. And I think for a lot of providers, understanding that really can be provided alongside curative care, and it's not, you know, older models would have been, it's more about end-of-life care, but really we strive to be in tandem with curative care. And really the focus is patients who have serious illness. So that's our definition and what we aspire to be. And you know, the realities of what we can do in different settings can change that as well, but this is in theory the definition of what palliative care is. To put it into pictures, I think for some folks that's easier. The left side of this graph here, if you think about getting a diagnosis like heart failure, a lot of therapy in the beginning that we focus on is really disease-directed therapies. So the top part, the majority of care at the early diagnosis of something is going to be disease-directed. Yet doing something like a durable power for attorney for healthcare is a palliative care intervention. It's thinking about, you know, who would be a surrogate in the event that this person got seriously ill and needed a decision maker. And in this model, anyone can do this. You don't need to call a palliative care specialist to come in and help with this. And so one of the strengths of this model, or framing it this way, is that really palliative care is something that I do as a specialist, but it's also something that all clinicians do as non-specialists. And we distinguish that in palliative care as primary versus secondary palliative care. And so what I'd say to you is early on, primary palliative care is probably the focus of what's happening, and disease-directed therapies are sort of the majority of what patients experience. In the model of heart failure, I often ask sort of medical students, how many people with heart failure do we cure each year? And there isn't a lot. If you really, I think of maybe heart transplant as a cure, and so about 2,000 plus a year. But otherwise, a lot of heart failure, the things that we're doing are palliative in nature, even when they're disease-directed. In this model, as time progresses along the bottom line, what you might see is the disease-directed therapies, there's less of what they can do, and then more of what we're doing is more clearly palliative in nature. And then I use this to then really draw in, where is hospice in the big picture of things? And hospice, just as a review, it's a form of home care typically, and is typically provided for patients who have a prognosis of 6 months or less, as best we can tell. And it generally comes in at the very tail end of palliative care. And so in this model, hospice is part of palliative care, but it's not the same. The things that we are doing here are not the same things that you are doing here. And so I think that's important for patients to understand and for providers to understand that if you're calling palliative care, it doesn't mean we're dealing with the last 6 months of life. We could be dealing with any part of this continuum. And the last thing I'll draw out from this picture is, when a patient dies, the picture continues, and this triangle is really about the family, and we think again of the model of patient and family. After a patient dies, hospice is actually legally obligated to provide 13 months of bereavement support, and a variety of palliative care services may actually provide some of their own bereavement support. And so again, thinking about after the patient has passed, what are we still doing and how are we still helping in the care of the family for that patient. So this is a pictorial way of representing what palliative care does in tandem with the primary services involved in the patient's care. The poll was interesting to actually see you guys answer the way you did. This graph here was put together by CAPC. It's 2017 data, and what it reports on is the last 15 years of inpatient palliative care consultation services. And in the early 2000s, about 20% of hospitals with 50 beds or more had a consult service. In 2015, we're almost at 80%. And so you've seen a huge expansion of inpatient palliative care. And so most hospitals in this country will have a palliative care consultation service. However, outpatient is really the next frontier. It's been building, I would say, since about 2010 in a lot of different places. And a lot of that is due to value-based care, sort of accountable care, if you will. As people see, the continuum of care is not just a hospital or not just an office, but the spectrum of home to office to hospital to facility. And so this is beginning to grow, but there is not data on what exists out there. And then home-based is also growing. And that often, when I see that, it's often in, if you reflect back on the previous slide, I talked about many hospices will extend their hospice service and do like a hospice light, which I would call what they're calling palliative care, and they'll do some of what they do on hospice, but with much less support. Or some hospitals and health systems have realized that there's certain frail patients that getting to an office is too hard, and so they end up coming to the hospital when things get really bad. So instead of having them use hospitals, they've figured out systems to bring home care to them. And so you'll see some home-based programs. But I was expecting on the poll to see a lot more this and a little bit less of this. So I wonder what our numbers on the poll were, but we can talk about that later. And then the last thing, which I've already talked about, is a lot of palliative care, the need cannot be met by specialists alone. And so all of the work that you all do out in the community as providers, you're doing some primary palliative care and engaging some of the work that we do as a specialist. So access, I think, will continue to change and grow, and it's going to be dependent on your community and variable. So I can talk to some of that today, but I think some of it will be unique to where you are and where you practice. I want to highlight two opportunities for folks who are interested in learning more about palliative care. The Cambia Palliative Care Center of Excellence is here at the University of Washington. It's a collaboration between the Cambia Foundation and the University of Washington. And it's really a center designed to improve research and education related to palliative care. And so, it's really in the Northwest region and nationally, but if there are folks in the community that are interested in learning more about palliative care, thinking about research in palliative care or educational opportunities, this website down here is one thing to look at. The second piece is actually an education program. There's a graduate certificate in palliative care that's meant for clinicians who are already practicing. It's a 9-month certificate program, and it's for those who are interested in expanding their skill set related to palliative care. Somewhere between primary and secondary palliative care is what this program will help you get to. Okay, so why palliative care and end-stage heart failure? As all of you know, when you care for patients with advanced heart failure, end-stage heart failure, they carry a high morbidity, there's a significant symptom burden, and there's a significant functional limitations. One study, for a veteran study, really showed that 60% of patients had fatigue, near 60% experienced shortness of breath, and over 50% were in pain. Advanced heart failure is highly lethal. When folks reach stage D life expectancy, they often have a less than 1-year prognosis. And their care, as they get more advanced, often increases in intensity and increases in hospitalization, especially at the end of life. And despite that theoretically sounding like a good thing, most patients experience that as a negative experience. And so that we aren't getting good patient satisfaction despite giving more care in a highly intense way. Then the last thing that I'll share from this paper that I'm referencing here is when they surveyed academic heart failure clinics, they found that most patients, there was a pretty big discrepancy between what they thought, how long they thought they had, versus what their actual predicted life expectancy was. And so there's a significant gap in sort of patient understanding and expectation about the prognosis. And I think as heart failure providers, or cardiology providers, or primary care providers, I think, one, we know prognosis in heart failure is hard, but we do have some signs to say, you know, time may be less or time may be more. But knowing that is not enough. I think being able to initiate the discussions and having the experience to have meaningful discussions is critical. I think the use of guided discussions, so tools or approaches to have these discussions, can really help inform medical decision making. And that if we don't do these things, we see that patients have an end-of-life course that's hospitalized and often doesn't meet quality marks. When we study sort of families that have lost a loved one to end-stage heart failure, did your loved one have a good end-of-life experience? And most will say no. So I think if we don't do these things, we're able to see the outcomes. And when we do them, I think overall the quality of care for patients improves. I put up this book by Atul Gawande. Many of you probably read one of his various articles that he's published in a lot of places. He wrote this book in 2014, Being Mortal. And basically, I would say he took palliative care and some of the approaches we use in talking with patients to the popular press. And how did he do this? He went to his colleagues at Mass General and said, his palliative care colleague, what do you do? And they basically said, look, these are 4 or 5 questions that we commonly ask all patients, regardless of their diagnosis, which helps inform us about who they are and what's important to them. And so, one, just getting a sense of what's the patient's understanding of their illness, or how do they interpret their illness. 2, what are their fears and worries? Goals, priorities, we often frame this, what are you hoping for? And almost all patients will say, I hope I live longer. And then you might say, all right, well, what are some smaller hopes? And then you start hearing about graduations or babies coming or getting to some travel or a variety of things. And so the real sort of things that people are doing. And then kind of where are the lines in the sand? What's unacceptable? What are things are you willing to sacrifice and what are you not? And then what would a good day look like? Or when's the last time you remember a good day and what did that day look like? So by getting into some of these questions, you actually learn more about who the patient is, and the combination of the content of who the patient is with the medical information. When you sum those two together, a plan of care often reveals itself. And I think to some degree that's the sort of the magic that palliative care providers might provide when they step into a room and have a conversation. But I think it can be done by a lot of providers. So other sort of common topics that come up, we often talk about surrogate decision maker and making, because that's a hard role to actually be in. We may be involved in conversations around ICD placement or deactivation of those devices. Code status is a common topic. Helping to talk through prognosis and think through the sort of complexities of that. Talking about intensity of end-of-life care when appropriate. Helping with symptom assessments, and then I find we often are involved in discussing inotrope use and risks, and so I was going to expand on that a little bit. Continuous IV inotropes are clearly a palliative intervention. They really help a lot of patients feel better, at least that's my clinical experience, but they do come at the risk of possibly an increased risk of certain cardiac death. But when you look at the patient narrative around inotropes, when this has been studied, they generally fall into 2 groups. And group A is one that would rather have, a shortened life. They're okay with that if their symptoms are a lot better. While group B is, they want longevity over everything, and they actually would be okay with more symptom burden, but more time. And so I highlight this because I think we all would assume that most patients just want to feel better, and they'd probably sacrifice time for that. And the reality is that's not true. And for many patients, it's about time. And that can come from a myriad of sort of social reasons, cultural reasons, spiritual reasons, and so digging into those various content areas can help inform how do we best meet the goals of this patient. The other thing, again, I want to get to a practical sort of clinical thing that's easy and tangible. I think in dyspnea, in heart failure patients, we see a lot of dyspnea. This model is put out by a colleague out east, Arif Kamal, and what he's sort of saying is dyspnea is common. We saw earlier that over almost 60% of patients are experiencing dyspnea with heart failure. And the model sort of suggests, look, is the disease modifiable? So could we use some of our standard medications to help improve cardiac function and output and fluid management? If yes, that's what we should be doing, and then reassess. However, if we get to the point where we've exhausted all of those, then what are our other modalities to help alleviate symptoms that patients may experience? There's a lot of things that people try out there. There's not a lot of evidence to support all of them. The things that are evidence-based, I sort of consolidated a table he has in this paper as well. For patients who are hypoxemic, oxygen helps. And that's been shown. There's a lot of evidence to support that. For patients who are normal oxemic or not hypoxemic, oxygen probably doesn't help. And so using oxygen in those patients probably is not indicated. Oral and IV opioids do help, and they help relieve the symptom of dyspnea. They don't actually fix any of the problems, but what I'll share with patients is, despite all the medicines we've tried to use, you're still having some severe symptoms. These medications, which we traditionally use for pain, have also been shown to help patients feel a little bit less short of breath when we give them in addition to the other medicines. And with that, most patients are willing to try. There's some evidence that actually a fan, so blowing a fan on someone's face or skin, has improved their symptom of dyspnea. And then for some patients, doing some pulmonary rehab can also be helpful. But I think the take home is that, there's a lot of things people try, like nebulized opioids and nebulized other agents that have not really been shown to work. And of the things that we do know at work, these are a few of them. So I think in summary, what I was hoping you'd take away from today is that, palliative care is a growing part of heart failure care. And I'll say in this hospital at University of Washington Medical Center, for our consult service, it's probably upwards of 50 to 60% of the patients we're seeing have some cardiac related condition. The access to community-based palliative care is growing, but it's currently varied from community by community. And so despite our poll saying we had a lot of access among the people polled, most of the country has inpatient access. Office-based is starting to grow, and home-based is even further behind. But I think as healthcare continues to move, we will see more of that. Many patients with advanced heart failure carry a high psychosocial and physiological symptom burden, and it's part of all of our jobs to help and assess that and treat it. And then dyspnea relief can be achieved with all oral and IV opioids. I highlight that because historically many providers have thought it's only morphine, and morphine is special. Morphine is not special, it's a class effect. And the other piece of why it's important to know that is morphine has neurotoxic metabolites that are renally cleared, and so if people have renal issues, you give them morphine, you can cause seizures. And so we go to other agents when people have renal issues, and many cardiac patients have renal issues. And so I would sort of call out, remember it's a class effect, and if you're going to be using opioids, consider all of them and consider the risks